Hi everyone, I'm Dr. Mohammed Bardi. I'm a practicing rheumatologist in Vancouver, British Columbia. Today we'll be using the L15 Clarius probe to do an elbow assessment. Specifically in rheumatology, this is a more focused, limited assessment of the elbow, looking at regions of enthisitis at the lateral epicondyle, and we'll look at the tricep insertion as well for enthisitis there, and I'll show you how you would assess for synovitis in the joint as well. So starting here first on the lateral views, you can have your patient positioned with a bolster underneath their elbow so you can get around the posterior aspect. But if you don't have access to that, you can also have your patient positioned like this as well when you do the tricep assessment, and they could put their hand down like that. So there's different ways to go through the positioning. Starting with the lateral elbow, in rheumatology, when we do our scanning, we want to maintain a gel layer at the top. This ensures that we're not compressing the structures to block any signal from our Doppler assessment when we're looking for synovitis or enthisitis or tenosynovitis. We can see the lateral epicondyle into view here, and we can see the radial head. And you can actually do a dynamic assessment here. I could get my patient to supinate and to pronate to look at the radial head. Between the capitulum and the radial head, there is a joint space there you can see in the center. And you can also look for synovitis if there's any sort of synovial proliferation, hypoechoic changes, distension, or Doppler signal when we assess for that. When you're actually looking through the common extensor tendon, you can see this at the top here, it's important to sweep through this. So as I'm moving around, I'm looking at the fibers. You can see a nice fibrillar structure here as you look through this. You'd be looking for pathological changes for any sort of loss of fibrillation, thickening, any tears. You could see anechoic changes or a gap in the tendon. And if there's any sort of enthisitis or bony growth where the epicondyle is. And you would also be looking for erosions specifically if you're looking for enthisitis. So it's important to kind of sweep through this area. Of the extensor carpi radialis, brevis is the most commonly associated with tennis elbow. You could assess for that kind of pathology here as well. So we've been looking at this both in longitudinal views. We want to get transverse views, so we rotate our probe 90 degrees. We start here, we can see a nice clear bony cortex. And as we start to move down, you can see this hyperechoic band of where the tendon is. We can use anisotropy to bring that tendon in and out of view. And you'll see I'm on the lateral epicondyle here, but as I go distally, I'm now in the joint space, and now the radial head comes into view. That same dynamic testing I showed you, you can do in these views as well. And when we wanted to assess for Doppler changes, here we want to interrogate the enthesis at the lateral epicondyle. So we want to look in this region. You may need to increase the depth of your Doppler box to look between the joint space, between the capitulum and the radial head. And again, you look at this both in your longitudinal views, and you want to assess this in your transverse views as well. So if we were looking at the synovial space or the joint space, we want to see in that space, is there any sort of Doppler signal?